I really welcome this opportunity to further discuss the results of the PRAETORIAN trial. And what I'll try to do is to keep the recap of the data brief so that we have a lot of time for discussion afterwards. So like you mentioned, the PRAETORIAN trial is the first prospective randomized study comparing S-ICD versus transvenous ICD therapy. These were all of the physicians involved. And the S-ICD obviously was involved to overcome some of the difficulties we know with transvenous ICD, especially the leads. And from the introduction, the S-ICD has been mainly used in the younger patient population. So the data that we currently have of S-ICD comes from registries with patients with a relative preserved ejection fraction. And from that data, we already know that there is a high shock efficacy with the S-ICD comparable to transvenous ICDs, that there are less ICD lead-related complications, especially in the young patients, but that in the initial trials, there was a high inappropriate shock rate at 1 year, varying from 8 to 13%, comparing the effortless and the IDE trial. So that has been relatively high. So to date, there had been no randomized data until the PRAETORIAN trial came out, and obviously we're interested to see how these variables acted in the PRAETORIAN trial. So the hypothesis of the PRAETORIAN trial is not in that selected young population, but in a conventional ICD population to investigate whether the S-ICD is non-inferior to the transvenous ICD with respect to major ICD-related adverse events. And I'd like to call that ICD trouble. And what is ICD trouble? Inappropriate shocks and ICD-related complications that require intervention with a special focus on lead-related complications. So the design of the trial is that to investigate that, to include patients with a class 1 or 2A indication for ICD therapy, not only primary, but also secondary prevention according to EU and US guidelines, with an important exclusion criteria that these patients had no indication for pacing, either Brady, CRT, or ATP. We randomized these patients 1-to-1 in 39 centers in the EU and the US, over 400 patients in the S-ICD arm and over 400 in the transvenous ICD arm. And then we followed these patients with a median follow-up duration of 48 months for the primary endpoint, the ICD trouble, complications, and inappropriate shocks. And since inappropriate shocks are part of the endpoint, obviously standardized programming is very important. And we had that in this study. And it was based on the PREPARE trial. That is a bit of an older trial by Bruce Wilker from 2008. So that means a VT programming zone from 180 to VF 250 and one burst of ATP in the VT zone for the transvenous devices. And S-ICDs were programmed with the same therapy zones. So I'm happy to mention that the data was not only presented at the HRS recently in the online sessions, but also published in August in the full paper in the New England Journal of Medicine. And from the data in that journal, you can see that from the baseline characteristics, we achieved our primary goal of investigating S-ICD in a conventional patient population, because as you can see here, the median age of the PRAETORIAN population was 63, more or less comparable to the age categories that we know from the SCUD-HEFT and the MEDD trials. Over 90% of the patients had an ischemic or non-ischemic cardiomyopathy, 20% had secondary prevention indication, and the median ejection fraction was 30% in this trial. Immediately jumping to the end result of the primary composite endpoint, you see here with 4-year follow-up that in transvenous ICD trouble was present in 15.7% of the patients. So that's a combined endpoint of inappropriate shocks and complications. And in the S-ICD arm, this was similar. So this was 15.1%, and that makes it with a p-value of 0.01 non-inferior with regard to the primary endpoint of ICD trouble in both of the arms. Obviously, it gets more interesting when you look at the data from the aspect of the individual endpoints in the study. So if you look at the device-related complications, you see that there was a difference in this study, so that in the transvenous ICD, there were more complications, 9.8% versus 5.9% in the S-ICD arm, although this was not statistically significant, but there was a clear trend in favor of the S-ICD. When you look at the inappropriate shock rate, it is the other way around. There were 7.3% at inappropriate shocks at 4 years for transvenous ICD and 9.7% in the S-ICD arm. This was also statistically not significant, but there was a trend in favor for the transvenous ICD. And after we presented the results, we had some feedback that physicians found that the inappropriate shock rate was relatively high, especially from what they know from transvenous ICD, so it was 7.3% at 4 years. But if you calculate that backwards to what that means in shocks per year, it's approximately 1.8% per year inappropriate shock rate for the transvenous ICD. And if you compare that to the PRAETORIAN trial that had 3.6% inappropriate shocks at 1 year and the MEDIT RIT trial that had 2.8% at 1.4 years, it's not that strange. So if you follow patients longer, they will get more inappropriate shocks. So the per year inappropriate shock rate was not that surprising, in my opinion, in this study. If you look at what the cause was of the inappropriate shocks, you see that in the transvenous ICD arm, from the 29 shocks, inappropriate shocks, 27 came from AF or SVT. So this is the main cause of inappropriate shocks in the transvenous ICD arm. And in the S-ICD arm, there's a different picture. Most of the inappropriate shocks were based on cardiac oversensing. So this is more or less better known as the T-wave oversensing issue. But there was also some accounts of atrial fibrillation inappropriate shocks. So when you look at the complication endpoints in this study, there are some interesting observations to be made. If you look at the infections, there was a double amount of serious infections in the transvenous ICD arm versus the S-ICD arm, 4 versus 8. And that was the other way around with when you look at the bleedings. Although the bleedings were defined also as if you were admitted longer in the hospital, that was considered to be a complication. I think we didn't define that correctly. So physicians, it appeared that physicians were more prone to admit patients a day longer in the hospital if they saw a big hematoma on an S-ICD than if that occurred in a transvenous ICD. It gets more interesting when you look to lead-related complications like pneumothorax, lead perforations, 4 versus 0, and the number of lead repositionings and lead replacement. And if you add all those lead-related complications together, you see this interesting picture arise that there's a clear, significant difference in lead-related complications if you look at the S-ICD versus transvenous ICD, 1 versus 6%. And this, in my opinion, is exactly the reason why the S-ICD was developed, to overcome these lead-related complications. And I think what you see here is that the curves are dividing over time, and I suspect that with longer follow-up, this will increase even more. So in any ICD trial, it's important to look at mortality. There is a numerical difference in mortality, 13.1% versus 16.4% at 4 years from transvenous ICD versus S-ICD, but this is almost all caused by non-cardiovascular death, like infectious disease and malignancies. If you look at the sudden cardiac death rate, the number was 18 in both groups. So there's no debate whether the efficacy of the S-ICD is similar to the transvenous ICD. That has not been an issue in this study. So I think this is a statistical chance that there's a slight difference, non-significant, in mortality in the study. When you look at the last part of the results that we analyzed, you can see here that there was a difference in appropriate shock rate, which was to be expected. So the S-ICD does not have an ATP capability, and you see here that in the VT zone, there were definitely more shocks in the VT zone in the S-ICD arm than in the transvenous ICD arm. Not all the difference of appropriate shock therapy is caused by the lack of ATP in the S-ICD arm. The SmartPass algorithm was introduced very late in the study. That's an algorithm that might prevent double counting also on slow VTs. So there were 11 slow VTs in this arm that also caused this higher appropriate shock rate. So another thing that we noticed was that only 55% of the ATP bursts in the transvenous ICD arm were successful, and that there were 7% of patients that received inappropriate ATP bursts. Also, I need to mention that this is only first appropriate shock therapy in the PRAETORIAN trial. We are still working on the analysis of all appropriate shock therapy, and that is going to look a little bit different than you see here, but we might be able to discuss that later. So for the last minute or two, I want to talk about some other interesting aspects that we noticed analyzing the data. So the procedural characteristics. It is important to notice that implanters in this study had much less experience implanting S-ICD than transvenous ICDs. So almost 60% of the physicians had implanted less than 70 S-ICDs in their career, while more than 80% had implanted more than 70 transvenous ICD devices in their career. So that is a real difference in experience implanting the devices. Another remarkable thing is that a lot of physicians think that it takes a lot longer to implant an S-ICD than a transvenous ICD, but then if you look at the procedure duration, the mean procedure duration of the S-ICD was 55 minutes versus 50 for the transvenous ICD. And the last thing I want to draw your attention to is the need for crossovers in this study. So there's always the question is, the lack of pacing, does that mean that you have to upgrade a lot of patients later on in the study with a pacemaker or switch to a transvenous device? You can see here that out of over 400 patients, only in 5 patients, a Brady pacing indication developed. So that's about 1% that needed to change to a transvenous device for a pacing indication, and only 1 patient because of repetitive need of ATP. So I think that's a very good statement showing that when you select patients for an S-ICD, physicians are pretty well capable of selecting patients that do not need pacing or ATP repetitively in the years to come. So one of the limitations of the study was that physicians, patients, and the clinical event committee were not blinded for the treatment allocations. Like I mentioned, the physician implant experience was higher for transvenous ICDs. And in my opinion, with the current leads, the median follow-up of 48 months might be too short to reveal the real chronic complications of transvenous ICD therapy. So therefore, I think it's important that we follow these patients longer, and we are planning to do that with the PRAETORIAN XL trial. We'll follow these patients for another 4 years. So my conclusion is that in the conventional primary and secondary prevention ICD population, the S-ICD is non-inferior to the transvenous ICD with respect to major ICD-related adverse events, so the ICD trouble. So there's a non-significant lower ICD complication rate in S-ICDs, with definitely less lead-related complications with the S-ICD, and there's a non-significant higher inappropriate shock rate in the S-ICDs. So there's obviously a debate on which of these endpoints weigh higher, ICD-related complications or inappropriate shocks. And I think I'm happy to discuss that later on with Ricky. But in my opinion, I think that the S-ICD, based on this data, should at least be considered in all patients in need of an ICD without a pacing indication. So thank you, and I hope for an interesting discussion, Ricky, and we'll see how far we get.
Thanks. That was a great overview of the study. We should maybe just go back to the issue of patient selection again, because it sounds like you feel very comfortable with most patients. A little lower percentage of secondary prevention patients in this study. Do you think that that matters at all? Anything in particular when it comes to patient selection?
I know that there's the opinion that secondary prevention patients, a lot of them with ischemic cardiomyopathy, have more chance of getting monomorphic VTs where there's a need for ATP. And we have seen that when we were analyzing a bit further in the appropriate shock data of the study, that physicians tend to treat an appropriate shock from an S-ICD differently than an appropriate ATP intervention from a patient with a transvenous ICD. So that means that I think that if you have a patient with a transvenous ICD that has monomorphic VTs and some bursts of ATP, doctors tend to not change something, either in medication or just to continue following that patient. While if you get a shock from an S-ICD on a monomorphic VT, I think that most physicians then do what you should do as a physician. You should try and prevent monomorphic VTs from occurring. So you should either change medication, ablate your patient, or check your patient's health condition if there's recurrent ischemia or something like that. So what I'm saying is that I think that a lot of the perception for secondary prevention patients is that they might not be ideal for S-ICD patients because you don't have ATP. But again, I think that having just ATP as your solution for monomorphic VTs is a poor solution.
I think it's good that you address this, because one of the concerns that come up with the use of the S-ICD is obviously that it doesn't have the ATP function. And I think that the data from the crossover of your study is encouraging to see. Now, what about bradycardia? And are you at all concerned that it doesn't provide the bradycardia function, which is another question that comes up when we select patients?
So like I showed in the data, the very low percentage of patients that end up developing a Brady pacing indication is really low. When you look at the publication in the New England Journal, we also added in the supplements a flow chart of how the patients for the PRAETORIAN trial were selected, and how hospitals went about in selecting patients for the PRAETORIAN trial and who they excluded. And so if you review patients for the PRAETORIAN trial, about 15% of the patients were excluded because of a perceived Brady pacing indication. What is a Brady pacing indication? Obviously, if you have AV conduction blocks, then you have a pacing indication. But physicians also deemed patients relatively poor candidates for S-ICD if, for instance, they had a very prolonged first-degree AV block, or if they were very bradycardic and they perceived that the patient would benefit from even more chronotropic medication. So in that sense, if you look at somebody's history, Holter monitoring, and if you know that they are free from pauses, if they don't have conduction disturbances on their EKG, then they are suitable candidates for an S-ICD, because based on those criteria, patients entered the PRAETORIAN trial, and we came up with this very low rate of patients that needed pacing. And it is encouraging to me that the same percentage was seen in the registries that were previously published with the S-ICD, but also in this somewhat older patient population, we had this very low percentage of patients that finally needed a different device for pacing purposes.
And before we hand the discussion over to Dr. Gold, I do want to ask you, what else can we expect from the PRAETORIAN study? What kind of interesting sub-analysis might there be? And I think that there are a couple of follow-up studies to the PRAETORIAN coming as well.
Yeah, so like I mentioned, the data on appropriate therapy is certainly not complete, because we only included the first appropriate therapy data from the study. We're also going to do an individual look on all inappropriate therapy and how that is going to look. We also have a quality of life analysis scheduled, so all patients had a quality of life assessment before implant, right after implant, and 1 year after implant. So I know it's a soft endpoint, but for patients, obviously very important. And for the results that I expect most from is the longer follow-up of the entire cohort, because I really think that the most of the complications are still ahead of us in the PRAETORIAN trial with the transvenous systems in place. So I really expect a lot from that.